right, we'll go ahead and get started. Good afternoon, everybody. My name is Diane Barish, and it is my pleasure to serve as your guest host this week for the CGNE seminar series. This program is being provided by the Teresa Neese and Helen Diskovich Center for Geriatric Nursing Excellence at the Penn State Ross and Carol Neese College of Nursing in collaboration with the Outreach and Professional Development Office, the Center for Nursing Research, and Age-Friendly Care PA. Today's seminar is titled Non-Pharmacological Interventions for Pain in People with Dementia, and it will be presented by Yo-Jen Liao, a CGNE affiliated graduate student who's working on her PhD, and Janice Whitaker, a member of the CGNE. She's the CGNE administrator and community liaison. So before this informative session begins, I have to read to you some disclosures and announcements. So the Penn State Ross and Carol Neese College of Nursing is approved with distinction as a provider of nursing continuing professional development by the Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission and Accreditation. Participants with a valid RN license who attend the entire nursing continuing professional development program can earn 1.0 contact hours. Partial contact hours are not awarded. The topic of this education is non-clinical, and therefore we do not identify, mitigate, or disclose relevant financial relationships. In order to earn contact hours, Zoom in-out times will be recorded, and the post-event evaluation survey must be completed. This seminar is being recorded, so if you have any objections to that, you are welcome to exit at this time. Questions will be addressed during the Q&A or discussion portion of the seminar in the following two ways. Either enter your question into the chat feature or feel free to use the raise hand feature to ask to be unmuted to ask your question in person. The post-event evaluation and survey link will be placed into the chat feature and also emailed to you within 24 hours. The evaluation must be completed within 1 week of the seminar. While this is required for RNs seeking contact hours, we do ask that all attendees complete the post-evaluation survey to assist with data collection related to our center activities and for the Age-Friendly Care PA project. Nursing continuing professional development certificates will be emailed to registered nurse participants meeting all requirements within 1 month following the seminar. If you have any questions or comments, please feel free to send those to our email at cgne@psu.edu. So next, I would like to introduce to you Susie Gong, who is a CGNE graduate student affiliate. She's currently enrolled in our DNP program with a focus on depression in the elderly population. And thank you so much for introducing our speakers today, Susie.
Thank you, Diane. It's my pleasure to join the event today. We have two wonderful speakers today. Yo-Jen Liao is a registered nurse and has clinical experience working with older adults in acute care and long-term care settings. She's currently a third-year MSN and PhD student at the Neese College of Nursing at the Pennsylvania State University. Her area of research focuses on pain in people with dementia. Janice Whitaker has served as the administrator and the community liaison for the Teresa Neese and the Helen Diskovich Center of Geriatric Nursing Excellence, Penn State Ross and Carol Neese College of Nursing since 2015. She provides oversight of the CGNE mission and the strategic plan involving education, research, translation of best practice, and service. As a member of the Age and Dementia Friendly Care PA initiative, Janice participated in the ECHO sessions and is responsible for community engagement activities for his geriatric workforce enhancement program. A former director of nursing in long-term care and skilled nursing rehab, Janice served as the expert panel for the COVID-19 Project ECHO in Nursing Home, a PCORI grant led by the Penn State College of Medicine She continues to collaborate with colleagues at the College of Medicine on the Long-Term Care RISE project, providing education and mentoring support to facilities in the South Central region of Pennsylvania. Janice earned a Master in Educational Leadership from the University of Vermont and a BSN at Hartwick College in New York. She has over 30 years of nursing expertise in various settings with an enhanced emphasis on geriatric for most of her career. Now I'm gonna pass on to the speakers for today. Thank you.
Thank you, Susie. I'll share my screen. Okay, so I'm presenting non-pharmacological interventions for pain in persons with dementia. This is a published article, and my co-authors are Dr. Berajuli, Dr. Liao, Dr. Kitko, and Dr. Barish. Objectives of this presentation is to identify the significance of pain in persons with dementia and to identify beneficial non-pharmacological interventions for pain in persons with dementia. A little bit of the background in dementia and pain. So there's currently around 50 million persons that are diagnosed with dementia worldwide, and pain is commonly experienced in persons with dementia. Evidence has shown that 1 out of every 2 individuals with dementia experience pain persistently. And if pains are not managed well, it can lead to cognitive and functional decline, increased agitation, depression, and mortality. Evidence has shown that if pain medication administered regularly in people with dementia can help with pain management, but medications in older adults, like persons with dementia, can cause severe side effects or adverse events because they commonly have comorbidities and polypharmacies and more risk of drug interactions. Non-pharmacological interventions can be considered as an alternative approach to help manage pain in this population. And if combined with medications, it can also help decrease the dosage of pain medications used for pain management. But evidence is still limited in testing non-pharmacological interventions in persons with dementia. So we did a systematic review focusing on non-pharmacological interventions for pain that was tested in persons with dementia, and we searched 4 databases: PubMed, CINAHL, Scopus, and Web of Science, and used 2 quality assessment tools, including Cochrane Risk of Bias tool and the Johns Hopkins Nursing Evidence-Based tool. We searched a total of around 2,700 articles, and after removing duplicates, screening for titles, abstracts, and full text, we ended up with 11 articles and 12 interventions. And these are the quality assessment results. So we can see that the overall risk of bias among the included studies are high, mixed to high, and there's 3 low risk of bias studies. Among these studies, most have a high risk in blinding either participants, researchers, or their outcome assessments. So I'll start with the interventions that had positive effects in pain management in dementia. For cognitive behavioral therapy, a total of 44 residents with dementia living in long-term care with mild to moderate baseline pain were included. Interventions were administered for 8 sessions in 5 weeks. Every session is 30 minutes long. They focus on chronic pain. Results showed that pain decreased from 5 to 3.4 out of 10 significantly. For tailored pain intervention, 30 residents with dementia living in nursing homes with mild to moderate pain were included. They provided 4 sessions, each session 10 minutes per week for 8 weeks. These interventions include massage, tense unit, exercise, stretching. not all participants received the same amount or type of the interventions. These interventions were tailored based on the participants' need, and they focus on chronic pain. Results show that pain decreased from 2.3 to 1 out of 5, but no significance level were reported. Another study tested the effects of reflexology and friendly visits in 21 residents with dementia in nursing homes with mild pain. They separated the residents into two groups. One received reflexology first, another received friendly visits first, and then exchanged the interventions. So the dosage of the interventions were 1 session per week for 8 weeks. Every session is about 30 minutes long, and they focus on pain in general. Results showed that reflexology decreased pain from 3.9 to 1.9 out of 6 and had significant lower pain scores than friendly visits. For ear acupressure, they included 111 residents with dementia living in residential homes with moderate pain. They separated the participants into 3 groups, one in massage group, an ear acupressure and control group. For the intervention, they put the seeds on the ear for 3 months, and they changed the seeds every 15 days and focus on pain in general. Results showed that pain decreased from 19 to 10.5 out of 30 in the ear acupressure group, whereas the control group had an increase in pain. I will present the massage later on in the slides. For personal assistive robot called Paro were tested in 43 participants living in long-term care with mild to severe pain. 21 was grouped in the Paro group and 22 in the control group. They provided the intervention 5 days per week for 6 weeks and about 30 minutes in duration and focus on chronic pain. They use 2 pain assessment tools, PNAT and the numeric rating scale. PNAT showed a significant decrease of pain from 0.8 to 0.6 out of 10, but the numeric rating scale, although it showed decrease of pain, but was not significant. For music therapy, it was tested in 15 participants living at home with mild pain. They listened to the preferred music 40 minutes before their peak agitation. Before they administer the intervention, they had a period of time where they measure agitation timing among the participants, and they administer the music intervention just before the peak agitation. And the dosage was 2 days a week for 2 weeks and focused on pain in general. Results show that pain decreased from 1.2 to 0.6 out of 4 significantly if they listen to music more than 30 minutes. Pain scene was tested in 59 participants living in a hospital with mild to moderate pain, 31 in the scene group and 29 in the painting group. And interventions administered 2 hours a week for 3 months and focused on chronic pain. They didn't report any significance level in each intervention. They grouped the intervention together to report the effects and show that pain decreased significantly in 2 out of 3 pain assessment tools. They did test pain reduction when they receive more than 6 sessions, less than 6 sessions, or how their pain was reduced after the most intense pain was reduced after the intervention was implemented. More details can be found in the article, but overall the pain decreased significantly in 2 out of the 3 tools they used. Play activity was tested in 53 residents in nursing homes with mild pain. 29 was in the play activity group, 24 in the control group. They administer the intervention once per week for 8 weeks, every time 1 hour, and focus on chronic pain. The results showed that pain decreased from 2 to 0.6 out of 10 significantly, and there's also a significant differences of pain reduction compared to the control group. For a person-centered environment program, 9 participants living at home with mild to severe pain were included. The program includes visual, auditory, olfactory, and tactile stimulation according to the participants' preferences. They provide the intervention twice per week for 16 sessions in total, and every time it's 30 minutes in duration, and focus on typing pain in general. Pain decreased from 1.89 to 1.16 out of 3 significantly. For the mixed effects of interventions, massage was the only intervention that was tested in more than one study. One showed that massage was not effective, but another one showed that it's effective. The one that didn't show effective, they included 10 residents from long-term care settings with mild pain, 5 in the massage group and 5 in the control group. They provide massage on pain location, which is self-report from the residents. They provide 4 times per week, every time 10 minutes for 4 weeks, and focus on chronic pain, and didn't show any differences of pain reduction between the intervention and the control group. Whereas another study that included 111 residents living in residential homes with moderate pain, this is the same study that tested air acupressure. 35 of the residents were in the massage group, and they massaged the limbs and back every weekday for 20 minutes for 3 months and focused on pain in general, and showed that pain decreased from 22.7 to 16.8 out of 30 in the massage group. And the control group, they had increase in pain from baseline to post-intervention. For the non-effective ones, this is the same study. They tested exercise and social activity. So a total of 91 participants living in the nursing home with mild pain were included, 44 in the exercise and 47 in social activity. For the exercise, they included balance, muscle strengthening, and aerobic exercise. And social activity included group-based non-physical activity like music, meditation, or arts. Both interventions were provided twice, 60 minutes per week for 24 weeks, and focus on pain in general. But their baseline pain on average was 0, so they didn't really show any reduce of pain after the intervention. So for discussion, most studies had mixed to high risk of bias, relatively small sample size, similar sample characteristics and settings. Most are white, female living in long-term care settings, and most have mild to moderate baseline pain, which may limit their floor effect. The pain assessment tools used among the studies vary highly. So a lot of different pain assessment tools with different total scores and pain assessment tool content, leading to challenges in comparing the results from all the different tools. Also, fidelity information was not reported among the studies, so we don't know if they adhere to the protocols when they implemented the intervention. However, considering personal preferences and tailoring interventions to the participants' need may contribute to a better outcome. Also, cognitive capacity should also be considered when implementing interventions to help achieve a maximum effect, such as, say, cognitive behavioral therapy, where participants need active participation, may require them to have a more cognitive capacity, whereas massage, it's more passive participation. So those with more severe dementia can participate in massage. For implications for research, since the quality is low to mixed, there's a need for more rigorous research design with a larger sample size, more diverse sample characteristics, and also include participants that actually have are experiencing baseline pain, and then test the intervention's effect on different severity and types of pain, not just only chronic pain or pain in general. Also test interventions in different dementia stages would be helpful to determine what kind of interventions are most helpful in different dementia stage. For implications for practice, overall, the positive effects of interventions are reflexology, music therapy, air acupressure, person-centered environment program, cognitive behavioral therapy, personal assistive robot, singing and painting, tailored pain intervention, and play activity. So for mild dementia, we can consider cognitive behavioral therapy, painting, singing, music therapy, or play activity. For those with more advanced dementia, reflexology, air acupressure, tailored pain intervention, or PARO can be considered to implement in this population. Also, when implementing, considering and tailor to their preferences and needs are good, and to reevaluate the effect of the intervention periodically to see if it's still effective in helping them with pain. And this is my presentation. Thank you. And my references. And I'll turn over to Janice.
Yes, well, thank you so much, Yo-Jen, for that amazing presentation, as well as inviting me to co-present with you today. So I am going to share my screen. Are you able to see it okay? Great. So I'm hopeful to share the long-term care clinical perspective with everyone today after that really informative research that Yo-Jen shared. As she mentioned, pain is common in people living with dementia, affecting at least half of all residents in long-term care settings. Clinical guidance and validated assessment tools to manage and detect pain in persons with dementia are limited. As dementia progresses and communication becomes less effective, differentiating pain from other causes of stress become more challenging. This can lead to underdiagnosis or inappropriate treatment of pain. Use of analgesic medicine may provide effective relief, but it's important to administer the safest medications and the lowest doses possible, as well as to evaluate the benefits versus the risks of medications that may have adverse consequences to older adults. And of course, the focus of today is our need to identify and implement non-pharmacological interventions in the treatment of pain. We are not moving the screen. Sorry, my PowerPoint is not moving. I apologize. Let me start that over. There we go. Maybe it'll be happy now. There we go. Are you seeing my next slide? I hope. Thanks for the thumbs up, Yo-Jen. So I'm going to cover some of the regulatory standards that relate to pain management for residents in long-term care communities. As most of you know, the guide is about 800 pages long, so I'll do my best to hit the highlights of those regulations. I'm also going to touch on some additional non-pharm interventions in the context of age-friendly care. So to promote quality improvement and develop policy and implementation of effective procedures and programming in long-term care, it's important to review the regulatory standards established by CMS and the Department of Health, as well as review other resources related to professional standards of practice. As you may know, the state operations manual is lengthy, but again, we're going to hit some of those, the important aspects related to pain management. In terms of resident assessment, comprehensive care plans, quality of life, quality of care, and it's always important to consider training requirements. So the facility must initially conduct initial and periodic, comprehensive, accurate, standardized assessments of each resident's functional capacity. And as many of you know, this involves the resident assessment instrument, which has 3 components: the minimum data set, or what we refer to as the MDS, which has 16 sections, and assessment in any one of those sections can trigger additional assessments through the care areas. And of course, the guidelines for this evaluation tools are part of the guidance. The assessment process yields information about the resident's functional status, their strengths, their weaknesses, and their preferences. And it should be done within 14 calendar days after admission. And anytime there's a significant change in condition for a resident, and at the minimum, at least annually. This slide shows, and I know you probably can't see this very well, but on the left, it's the section J from health conditions that relate specifically to pain management, which helps the RN doing the assessment to gather information about the presence of pain, including frequency and severity. If the resident is not capable of being interviewed, then a staff interview is done to assess for possible indicators of pain. This section can also trigger CAW number 19, which is specific to further evaluation of pain in relation to diseases or conditions that may result in pain. Electronic health records often include pain management tools, and paper forms can also be used by some care communities. Everyone's probably familiar with the Wong-Baker-Faces pain rating scale and the universal pain assessment tool on the left. They're often visible in the emergency room and doctor's offices. And while the FACES, the 0 to 10 scale, and the basic descriptors can be valid and reliable with alert and oriented older adults, they have very limited effectiveness with people that have cognitive or communication difficulties. More detailed tools requiring observation of a person with dementia should be used. And I'll briefly share a few examples. On the right of the screen is the PAINAD scale that Yo-Zhen also referred to. This involves observation of the resident for 5 minutes related to 5 behaviors: breathing, negative vocalizations, facial expressions, body language, and consolability, which are the most common nonverbal pain behaviors. It's usually implemented when pain is suspected by the staff. On the left side of this screen is the ABBY. It's an Australian tool developed to measure the intensity of pain in people who are unable to communicate verbally, such as people in the moderate to late stages of dementia. It includes 6 items and intended to be completed on an ongoing basis at specific intervals. So you can see the columns that it provides, as well as when pain is suspected. And then the even more comprehensive tool to the right, the pain assessment checklist for seniors with limited ability to communicate, developed by a Canadian team, includes 4 categories and a checklist of 60 items identified by the AGS guidelines related to pain. So another regulation that's really important after all of the great quality assessments are done on a particular resident is developing care plans. A baseline assessment needs to be done within 48 hours of admission, and then a more comprehensive plan within 7 days after the completion of the comprehensive assessment. The facility must develop and implement a person-centered comprehensive care plan for each resident. The resident and their representative should participate in the development of the care plan, and certainly depending on the stage of dementia, it's that much more important to have family or their representative involved. The resident should be the locus of control. It should be based on their goals for care and quality of life, as well as their choices and preferences. There should be an interdisciplinary approach to the development of the care plan. It should meet their medical, nursing, mental, psychosocial needs. It should document the care and services being provided. It must be specific, measurable, and have specific timeframes as well. And the guidance actually has a specific component to it involved with interventions related to pain, related to the care plans, making sure that evaluation is done after an intervention, especially analgesia is mentioned. But I think it's also important if a non-pharm intervention is implemented, that reevaluation needs to occur then as well. And the care plan needs to be communicated and education provided to staff across all shifts, which includes weekends, and on the specialized interventions for each individual. Quality of life is a fundamental principle that applies to the care and services for all residents. And facilities are required to attain or maintain the highest practical physical, mental, and psychosocial well-being for each resident in their care. And according to a report by IOM in 1986, there's two principles of quality of life that are important for residents in long-term care. One is that they have a sense of well-being, satisfaction with life, feeling of self-worth and self-esteem, and also that they have a sense of satisfaction within the long-term care environment that respects their goals and their locus of control over their care and life. So in terms of quality of care, this is probably the biggest component of the manual, but it's another fundamental principle of life in a long-term care facility, that the facility must ensure that residents receive treatment and care in accordance with professional standards of practice, the care plan that's been developed, and the resident choices. And again, striving for the highest practical physical, mental, and psychosocial well-being. And that's not only in relation to diseases or pathology, but also in relation to the normal aging process. It should be noted that the MDS and other assessment methods do tend to focus on diagnoses. So sometimes we're looking for arthritis that might be causing pain, but we also need to recognize that normal aging can result in an increased risk of discomfort. For example, as people age, joints have less synovial fluid, cartilage can be damaged, there's less cushioning in a person's spine. All of these changes can result in either transient aches and pains or can result in chronic discomfort. So it's important to consider that as well. And in addition to striving for the highest practical well-being for all residents, regulations provide specific guidance for hospice, palliative care, as well as for the terminally ill. And we know that pain management is critical during those parts of life. So quality of care actually has some specific guidance related to pain management, that the facility must ensure that pain management provided to residents requiring services aligns with professional standards, their plan of care, and the residents' goals and preferences. As we know, nursing home residents are at high risk for having pain. Both verbal and nonverbal signs of suspected pain must be evaluated, and that pain it's important to remember that pain impairs function, mobility, mood, sleep, and quality of life. That's why a lot of these regulatory standards are intertwined. And in order to achieve good pain management, we need to recognize, evaluate, and manage pain. So a couple of deficiencies that I'll just highlight real quickly that are specifically mentioned in the manual that relate to our topic today is, case number 1, where it was an evening shift, nursing assistant providing care to an older adult. The older adult was having some back discomfort and requested a hot shower. And in that moment, the nursing assistant didn't feel that they could provide it to the resident. They had other things apparently on their assignment they needed to do. But fortunately, another nursing assistant stepped in and gave that resident the shower. They did get cited because of the delay in that care. So it's really important to take a look at what the root cause was in that situation, what prevented that nursing assistant from being able to provide that hot shower, maybe some re-education, some systems review needed to be looked at to prevent that from happening again. And in the second case, it's related to medication, but I believe we can also relate it to non-pharm approaches as well, in that the resident was receiving pain medication when requested, but there was no reevaluation as to the effectiveness of that intervention. So the same could be true if we implemented a non-pharmacological approach to pain, but didn't go back to the resident within 30, 45 minutes maximum to reevaluate to see the effectiveness of that. So with any type of quality improvement, staff education and training is essential. And this not only should be to improve knowledge and skills, but to check on competency related to that aspect of care. And there's a couple really great resources listed on this slide. The Nursing Home Toolkit is great for helping to address behavioral concerns related to dementia, which can also help to kind of sort through, is this distress because of pain or is it distress because of something else? And then identify that need that can get addressed. And then the emotion-focused training developed by Dr. Kimberly Van Heidsma and colleagues, I think is a really great foundational training for direct care providers that helps them recognize their own emotions as well as the emotions of others as they provide care, which I think is an essential component of dementia care. So now I'd like to shift to talking about non-pharm interventions in the context of age-friendly care. And all of this, of course, is related to each other. And as many of us know, the framework for age-friendly care involves the 4 M's: what matters, medication, mentation, and mobility. And in each of those areas, it's important to assess and act on them. So what matters is about knowing and aligning care with the person's goals and preferences. So in terms of assessment, really important to assess their history of pain, specific diagnoses, but also have they ever had any injuries? What impact do age-related changes have on their discomfort? We also want to know what their goals are for pain management, as well as their history and customary routines on a regular basis. And what are some of their preferences for non-pharm approaches to provide comfort and reduce pain? Some people like ice packs, others do not. So really important to know upfront, especially early on, when a person has dementia, what are their preferences for pain management? And then, of course, we want to care plan those using a strength-based approach, as well as their input and their family's input into the interventions that are selected. A few other great resources in terms of doing those assessments. Many EHRs have a tool like My Life Story that can get at some information, but as many of us know, the PELI is a very comprehensive assessment that inventories customary routines, preferences, and about care as well as quality of life. Another M is medication. And even though our focus today is on non-pharm approaches, it's so important to reconcile and review medications lists to identify any unnecessary or potentially harmful medications, but also to look at those that might be contributing to discomfort and pain. And also pain, if analgesia is used, making sure that we monitor the effectiveness of that. Deprescribing as often as we can to reduce or discontinue any medications that are unnecessary or potentially harmful. And again, emphasizing non-pharm approaches. And under this M, I wanted to just comment about the use of either heat or cold for pain. We had the example of the hot shower. We could use warm towels. Many care communities have blankets that can be warmed, blanket warmers. And often people are comforted by warmth. Even weighted blankets can be of value to some people when they're uncomfortable. And then any type of comfort therapy or relaxation technique, whether it's breathing, some type of companionship, distractive activities, guided imagery, meditation can be of a lot of benefit. So in terms of mentation, that we want to always prevent, identify, and treat delirium, dementia, and depression. That's the focus of this M. And again, assessment is a big part of that, but in terms of it relating to pain management, I think it's really important that we make sure that when a resident has a significant change or is showing distress, that we screen for delirium, we watch for changes in their cognition, but also potentially assess for depression as well, if that's indicated. In terms of mood and behavior, it's also very important to monitor that on a regular basis, be able to watch for changes. And non-pharm approaches that are especially helpful if a person is exhibiting discomfort that's impacting their mood as well. Could be counseling of some type, whether it's one-on-one or group. Again, some distraction activities, maybe it's art or something else that they enjoy. Many care communities are implementing what are called the music and memory program. And I know Yo-Jen mentioned music being a benefit to older adults experiencing pain. In addition, there was a positive effect with the Pero, which my understanding is that's a fairly expensive robot. Something that's a little less expensive may not be quite as high tech, but I've seen anecdotally it be very soothing, is the use of robotic therapy pets, often with older adults that have had pets in their life, and they find those pets very comforting. Sensory stimulation, whether it's aromatherapy or light, can be of value. Massage, you know, I'm kind of an old school nurse where I think that massage during AM care as well as at bedtime can have a lot of value with relaxation and promoting sleep. Therapeutic touch, there's actually a resource on this slide for a program called Compassionate Touch, which is a specific technique that can be used to increase comfort and reduce distress. And visits. Again, it's that companionship component, whether it's in person or certainly during the pandemic, we saw the value of virtual visits that can be really helpful with family and friends. And mobility, as I mentioned earlier, with normal aging, people can often experience more discomfort, let alone with specific diagnoses. But this M is intended to ensure that all older adults move safely as well as maintain their function to do what matters. And it may seem counterintuitive if someone's having discomfort or pain, but when it's appropriate, it's so important that we keep people moving in whatever way we can. And so some of the non-pharm approaches to pain that involves movement, not at the time of having movement, of course, but can help to reduce pain over time, is allowing the residents to stretch as much as possible. Often in a care community, someone might try to stand up from their chair or wheelchair and they're cued to sit back down. Sometimes they need to stand and stretch or move or walk, transferring to a different chair, repositioning them, ambulation programs, or even just increasing the amount of ambulation, whether it's from their bed to the bathroom or from their room to the dining room, or participating in a walking club can really help. Exercise programs, whether they're in their chair or up and moving, stand in a standing position, can be helpful not only with activities departments, but with the restorative nursing program, which can also do some range of motion. And then of course, more specific physical therapy, occupational therapy techniques that target reduction in pain are also listed here. So here's a few of my resources, and thank you so much. I know we're probably getting close to our time to do the evaluation as well as a little bit of Q&A. So thank you for listening.
Thank you so much to both of our panelists, Jen and Janice, for that wonderful information. And as Janice mentioned, yes, we have our evaluation link that we would like to just take a few minutes and have everybody go ahead and fill that out because we really value your feedback. And if you are an RN looking for those contact hours, you will need to complete the survey. So if you just click on that link, we'll give you a few minutes and then we will come back for question and answer portion. All right, so that was 2 minutes exactly by my timer. So we will move on now to the question and answer portion of our event. So just a reminder, if you have any questions that you would like to ask either of our panelists, please feel free to either type that into the chat feature located at the bottom of the Zoom screen, or you can raise your hand. That's also located at the bottom, and we will unmute you so you could ask your question in person, whichever you prefer. So we'll wait for a second for people to put in some questions, but I actually had some that I totally didn't arrange ahead of time or anything. So I had a question for Yo-Jen. I know that, nurses and CNAs and everybody working in nursing homes already have a lot on their plate as far as, workload and everything that they're being asked to do. And it's a very highly regulated, as Janice was taking us through all those regs, industry in general. So what would you recommend as far as everything that you've gone through and all the different kind of non-pharmacological interventions that you kind of sorted through with all the research? What would you recommend as sort of an intervention that someone could try that would keep the workload low, but the potential benefit for the resident could potentially be high?
So good question. So I think, well, while I was collecting data with Dr. Joe last year, we actually observed that the activity staff actually helps with providing some non-pharmacological interventions, like what Janice mentioned, the robotic PET and the music memory program. So I think it would be a good idea to introduce maybe different staff that's not only the nurses that are implementing the interventions, but other staff can help with intervention implementation. Maybe even if nurses identify that, oh, this person with dementia is actually experiencing pain, maybe we could try this intervention and maybe ask if other staff could help with it. That would make the resident have the intervention being received, but the workload of the nurses would not be increased, if that makes sense.
Can I tag on to that a little? I think that when you find an effective intervention, and of course it can change over time, depending on the resident's needs changing and the effectiveness of the intervention from day to day. But using the robotic animals as a great example, and I was, excited to see the positive effect of, the Paro. I was thinking about a resident that we had that was showing different signs of distress, wandering in her wheelchair, looking kind of for attention, but there's obviously a need there, wanting to converse with staff at the desk frequently. And we were trying to sort through, was she having pain or something else? And in interviewing the family, because she wasn't able to express her needs well or what was going on well, she always had a pet. She always had dogs, actually. And when it was like almost night and day when she was given a puppy from the activities department, a robotic puppy. She had it in her lap 24/7. Only when she wasn't in the shower did she not have it in her lap. So, even when she was seated at the dining table, the puppy was there. It just gave her so much comfort and kind of de-escalated a lot of those symptoms we were seeing. So just a quick example.
Thank you. And I see in the chat that we've had a couple of requests for Janice to share some of the sources in terms of pain assessment tools. And we're happy to share any slides, and Janice can forward you that information. If you just send us a quick email at CGNE psu.edu. So if you just send us a quick email, we'd be happy to share those sources with you. So then we do have a question that's come in from Dr. Boltz, and she asks, Janice, what approaches do you find helpful to support embedding best assessment practices in operations? And Yo-Jen, she said you did a fabulous job. Well, I guess there's two questions. Let's start with Janice's. I'm sorry.
Yeah, well, I certainly would love to hear Marie's take on this question too, because I'm sure she has a lot of expertise in this area, having served in many leadership capacities in long-term care herself. But I think that it's so vital, as I did kind of today, it's just natural for me to start with the regulatory standards to make sure that not only the leadership and the people developing policy and procedural guidelines are very well versed in those, but also, researching best practice approaches and those kinds of things. And then making sure that the policies are clear and concise, that education and training is done not only to build knowledge and skill, but then doing some competency checks. I always also found it really helpful to do a lot of reading of charts to make sure that the documentation is reflecting the care that's being provided, or if we see any problems there. But I think that assessment in particular, I think you do have to look at the resources you have readily available in terms of the EHR, and then add some additional ones that you think would add value for your staff as well. So, and I don't know, Marie, if you want to, I don't know if you can unmute and share some of your insights if you want to. That would be great as well. But I think one of the challenges, and Yo-Jen and I talked about this, is finding the assessment tool that is not only efficient and effective, but high quality, especially in relation to people living with dementia that can't communicate their needs verbally. And I think what we're learning too is that it's not just looking for suspected pain and assessing in that moment, but doing it on an ongoing basis with older adults that have dementia, especially in the later stages of their dementia.
Thank you, Janice. And Marie said you covered it very well. We've also got a lot of compliments in the chat if you guys want to check it out. But then for Yo-Jen, Marie's second question was, how have the results of your systematic review informed your plans for future research? And I think this will probably be our last question here.
Thank you, Dr. Boltz, for the question. So, although this study covered non-pharmacological interventions, but we identified that since there's a lot of different pain assessment tools that are used in different in these included studies. So I want to look more towards pain assessment in my dissertation, whether these assessment tools are the caregivers using them, what are in those assessment tools. Are they evaluating a comprehensive pain assessment? Say they only look at pain behaviors. Are they looking at pain related diagnosis? Are they looking at their environment, what activities they're doing that may lead to like discomfort behaviors? So I want to look towards this a little bit, if that makes sense, but I am still coming up with a plan. So this is just a direction.
Well, at least you know the path that you're walking, and you'll find that exact route as you move down it. So that's wonderful. And we wish you all the best as you move through the rest of your PhD program. Again, thank you both so much, Janice and Yo-Jen, for all the excellent information that you provided for us today. To our audience, thank you for being here and joining us. We really appreciate it. If you weren't able to complete that evaluation tool, feel free to take a moment now and get it off your plate. Or if you there'll be an email sent out within 24 hours and the link will be included in there as well. If you are an RN looking for contact hours, just remember that needs to be completed within 1 week of today's presentation. So thank you all so much for joining us and have the rest of your day. I hope it goes very well.